Here's another clinical toxicology video discussion. The topic this time is botulism, corresponding to Goldfrank's Chapter 38 and Antidotes in Depth Chapter A6. The learning objectives for this session are that you'll be able to describe the clinical signs and symptoms of botulism, identify at least 3 mechanisms for developing botulism, and outline a treatment plan for botulism, making sure to include the relevant immunotherapy options. Botulinum toxin is a neurotoxin produced by the bacteria Clostridium botulinum and some closely related Clostridial species. It's a protein toxin, so it would be ridiculous to try to show its chemical structure in fine detail, but here's a space-filling molecular model that I think looks cool. And it's the most potent toxin known, with an estimated human oral lethal dose of only 1 microgram. Clostridium botulinum is a gram-positive anaerobic rod that can form spores, and the spores are very environmentally resistant, a way essentially for the bacteria to kind of hibernate when the conditions for it aren't great. But then, when the environmental conditions get better, the spores can germinate and the bacteria can grow, reproduce, and start synthesizing and releasing their toxin. There are 7 serotypes of botulinum toxin, identified by the letters A through G. All of the toxin serotypes can cause botulism, but an antibody against one serotype only works against that specific serotype. And these serotypes have differing geographic and epidemiologic characteristics. Within the United States, for instance, we tend to see type A more west of the Mississippi River, type B east of the Mississippi, and type E around the Great Lakes and in the Pacific Northwest, including Alaska. Serotypes A and B are the types typically found in foodborne botulism from poorly processed meats and vegetables. Type E is more associated with raw or fermented marine fish and mammals. Types C and D are not typically seen in humans, but occur in other mammals like livestock and poultry and wild birds. And types F and G are so unusual, I've got nothing more to say about them. To know how botulism toxins work, we first have to look at normal neurotransmitter release at cholinergic nerve terminals. The presynaptic cells have acetylcholine packed into vesicles, which will fuse with the membrane through the action of snare proteins, allowing the acetylcholine to enter and then traverse the synapse, where it will bind to acetylcholine receptors and either result in muscular contraction, as shown here in the figure, or in providing cholinergic stimulation to a downstream organ under autonomic control. All of the botulinum toxins interfere with the snare proteins by proteolytically cleaving them, although in a few different ways depending upon which serotype we're talking about. This impairs fusion of the vesicles, reducing acetylcholine release, and therefore causing weakness or paralysis through impaired function of the neuromuscular junction, and/or resulting in some antimuscarinic effects at various autonomic effector organs. Botulism can occur from a few different botulinum toxin exposure mechanisms. The classic form of botulism, the one that was described first historically, is foodborne botulism. There is an infantile form of botulism which is associated with honey consumption as depicted here. Not all cases of infant botulism, though, occur from honey, and there are some other distinctions we'll get to shortly. There's also wound botulism, where there's an actual clostridial infection going on. It's possible to get iatrogenic botulism if the doctor injects too much Botox, and lastly, it's possible to inhale the toxin and develop botulism that way. To date, this has been limited to a few unlucky laboratory workers, but it's more than just theoretically possible for a country or well-funded terrorist organization to intentionally develop a respirable preparation of botulinum toxin and use it as a bioweapon. But we're only going to be discussing the first 3 flavors of botulism listed from here on out. Foodborne botulism results from ingesting preformed botulinum neurotoxin in food that had been contaminated with Clostridium spores from the environment. If the spores like their new surroundings, say if it's not too acidic and not too salty, and especially if it's warm and they find a spot low in oxygen, they'll germinate into bacteria, start to multiply, and to elaborate neurotoxin. And it's this preformed botulinum toxin that gets ingested along with the food. Foodborne botulism has a subtle GI phase where the patient may develop nausea, vomiting, abdominal pain, usually the day after the ingestion. And then between 12 hours to a few days later, they start to develop the neurotoxic effects. These effects start at the top and then progress downward. So initially, the patient will have neuropathies of the cranial nerves. They can have double vision, blurry vision, fixed dilated pupils, and their eyelids can droop and they'll complain of a dry mouth. As you can see, some of these effects are anticholinergic due to impaired ACH release at autonomic organs in the head and neck. Because botulism is quite rare and patients can present with early, relatively minor symptoms that don't fit a clear picture, it's pretty common for the diagnosis to be missed at a patient's first visit to the doctor's office or hospital. Then the neurotoxic effects start moving down the body as a descending flaccid paralysis. The patient can have bilateral facial droop, trouble swallowing or speaking, and the big danger is when the weakness or paralysis reaches the muscles of respiration and the patient can't breathe well enough to live. Cognition is not impaired, and these patients are awake, knowing that they're getting weaker and having trouble breathing, but it's getting harder and harder for them to signal that something's wrong because they're too weak to do so. Just terrifying. Here are photographs of a patient with botulism showing eyelid drooping or ptosis, facial diplegia, weakness on both sides of the face and a lack of any expression, and when the examiner pulled up the eyelids, because the patient couldn't do it, we see the dilated pupils. With one patient I saw in the emergency department, the medical student who first saw her told me, "The patient looks sleepy, but she isn't sleepy," and that sentence didn't make sense to me. I went into the room and she indeed looked like she was very sleepy, lying back with her eyes nearly closed, but she was carrying on an otherwise normal conversation. I lifted up her eyelids and she said, "Oh, hello doctor, I couldn't see you until just now." Spoiler alert, it was botulism. Infant botulism differs from classic foodborne botulism in that the baby has ingested botulism spores instead of preformed toxin. And those spores germinate in the infant's GI tract, and the bacteria propagate and then start producing toxin. We are all presumably ingesting clostridial spores all the time, but there are defense mechanisms in the normal adult and older child gut, like a lower stomach pH and a more mature microbiome, preventing this from happening. But those defenses aren't present in very young children. There is an association between infant botulism and not only ingestion of honey, which presumably contains spores, but also with the infant's parents' occupation. And if their occupation has them in frequent contact with the soil, they're probably tracking clostridial spores into the home. Infant botulism presents with floppy babies. They also get GI effects, especially constipation, and they can't feed normally and often can't even hold up their heads. The child in the upper right has a nasogastric tube in place to provide nutrition since they aren't eating well. In recent years, there have been many more cases of infant botulism, around 70% of all botulism cases, compared to foodborne, between 10 to 20%. The remaining botulism cases are from wound botulism. Wound botulism results from Clostridium bacterial infections in wounds or abscesses where the bacteria are now actively producing botulinum neurotoxin. Since the bacteria is an obligate anaerobe, presumably there are anaerobic areas within these wounds where the bacteria thrive. Wound botulism was originally described in people with deep crush injuries, but is now most commonly seen in patients who inject drugs. And there may be a component of poor skin hygiene and/or drug contamination and/or commensal infection with other more common bacterial species going on. A large proportion of wound botulism cases have been reported from California and often associated with black tar heroin, which is a particularly impure preparation. Treatment of botulism consists of advanced supportive care and administration of botulism antitoxin as passive immunization. I haven't used that term passive immunization previously in this course, but it's exactly what's going on with any kind of antivenom, providing the patient, who is passive in this sense, with antibodies their body doesn't have, but they need to bind up and neutralize the toxin. And I know I've said that supportive care is key in toxicology before, but with botulism it is really a primary treatment. The real danger with botulism is the patient suffocating to death from poor ventilation. They need close monitoring of their ventilatory status if indeed they didn't already need endotracheal intubation. With regard to the GI tract, you need to consider activated charcoal and GI emptying measures in foodborne and infant botulism. And the specific antidotal treatment is antitoxin. In the past, there used to be a few different preparations covering either 1, 2, or 3 botulism serotypes. But the decisions are much easier now since there is currently only a single heptavalent botulism antitoxin containing horse Fab2 fragments. As with any animal-derived protein product, there's a risk of early allergies and delayed serum sickness, but these can be treated and are much less dangerous than untreated botulism. This isn't a product that any hospital stocks, and to get it, you have to call your local health department and talk to the on-call epidemiologist so that arrangements can be made to get some couriered to you. And this will probably involve them contacting the Centers for Disease Control and Prevention in Atlanta. And for diagnostic confirmation and epidemiologic purposes, they'll want you to get samples of serum, stool, gastric contents, and/or wound swabs before you give the antitoxin. In cases of wound botulism, there's presumably an active clostridial infection going on, so the patient will also need antibacterial antibiotics and consultation with an appropriate surgeon for wound debridement. Penicillin G is a good choice for Clostridia, but you need to avoid antibiotics that have known effects at the neuromuscular junction, like aminoglycosides, fluoroquinolones, and clindamycin. For cases of infant botulism, there's a different product available called Baby Big, which is a human-derived botulism type A and type B antitoxin that's only available from the California Department of Public Health, and I've listed the phone number you'd need to call for the Infant Botulism Treatment and Prevention Program on-call physician. And that's it for botulism and botulism antitoxin. I'll be seeing you around.